All right, guys, today we're going to be doing all pediatric and neonatal resuscitation for the 2025 American Heart Association guideline updates. And I'm going to start with BLS and PALS, and then I'm going to go jump right into neonatal resuscitation. But first, let's go ahead and talk about some of the highlights that were discussed. We're going to go ahead and start here with the major new and updated recommendations: drug administration during cardiac arrest. For infants and children in cardiac arrest with initial non shockable rhythms, it's reasonable to administer the initial dose of epinephrine as early as possible. Non shockable rhythms, we're going to give epi immediately, just like with the adult, PEA, and asystole. It says a recent systematic review of 7 observational studies identified the shorter time to administration of epinephrine in out of hospital or in hospital cardiac arrest was associated with an increased rate of favorable outcomes. Time to the first dose of epi, less than 3 minutes, was associated with the highest rates of favorable outcomes, although there was no direct comparison across to first epinephrine dose intervals. So we know that epinephrine is still the golden standard for PA and asystole. They're just saying give it as soon as possible. I think that's pretty status quo. Let's go in and look at measuring the physiology during CPR. For infants and children with invasive airways in place during CPR, entitled carbon dioxide readings may be considered to monitor CPR quality. Haven't we been doing this forever? A specific EtCO2 cutoff value alone should not be used as an indication to end resuscitative efforts in infants and kids. Monitoring exhaled carbon dioxide levels among patients receiving CPR with an invasive airways is important because EtCO2 reflects native cardiac output and ventilation efficacy as well as feedback on CPR quality. In a retrospective multi-center study that evaluated average EtCO2 during the first 10 minutes of in-hospital CPR in kids, entitled values of 20 millimeters of mercury or greater during CPR were associated with increased odds of ROSC and survival to discharge, as well as higher intra-arrest blood pressures. There was no association with CPR quality metrics such as chest compression rate and depth. However, when rescuers are considering termination of resuscitation efforts, it is vital that they avoid using specific EtCO2 cutoff values alone because survival has been noted in patients with average entitles less than 20. So maybe that was like a protocol that some people had where they were cutting off or terminating CPR based on how low that entitle was going, maybe. I've never heard of anything like that, but they're saying don't do that. For infants and children with continuous invasive arterial blood pressure monitoring in place during CPR, it may be reasonable for healthcare professionals to target a diastolic blood pressure of 25 or greater in infants and 30 or greater in kids 1 year of age or older. Again, not something that we're going to be doing pre hospital, but let's see why they're mentioning this. New study shows that among pediatric patients receiving CPR with an invasive arterial line in place, rates of survival with favorable neurologic outcome were improved if the diastolic blood pressure was at least 25 in infants and at least 30 in kids. Treatment of SVT with a pulse. Let's see what they changed here. For infants and kids with SVT and cardiopulmonary compromise, unresponsive to vagal maneuvers, adenosine and electrical synchronized cardioversion, and for whom expert consultation is not available, it may be reasonable to consider intravenous procanamide, amiodarone, or sotalol. Interesting. So in 2020, they removed giving amiodarone to pediatrics in like TAC. Now they're saying that if the patient is basically refractory, so they're not getting any better from vagal maneuvers or the adenosine, you can now consider an antidysrhythmic. And I thought that they removed sotalol. So sotalol should be in the pediatric algorithms, which we will see here in a minute. Procainamide and amiodarone are moderately effective treatments for adenosine resistant supraventricular tachycardia, although adverse effects may occur with both therapies. Sotalol was approved for the treatment of SVT in 2009, with several studies demonstrating effectiveness in acute conversion of SVT, when it is administered under the guidance of pediatric electrophysiologists in acute care settings and reporting minimal adverse events. So now they're saying that, hey, it's pretty safe to do out in the field. For post cardiac arrest management, after cardiac arrest in infants and children, it is recommended to maintain a systolic and mean arterial blood pressure greater than the 10th percentile for age. I always thought that doesn't mean much to us out in the field. I don't know what greater than the 10th percentile of that person's age is. I rarely see protocols written like that, but let's see what it says. Because blood pressure is often labeled in post cardiac arrest periods, recognition of hypotension less than the 5th percentile of age and sex is important. Hypotension is commonly following return of circulation from cardiac arrest, occurring in 25 to 50% of infants and kids. Two observational studies associated systolic blood pressures below the 5th percentile of age within the first 12 hours following the cardiac arrest would decrease rates of survival to discharge. In addition, a secondary analysis of the ICU resuscitation trial of pediatric and hospital care found higher rates of survival to hospital discharge, as well as survival to hospital discharge with favorable neurologic outcomes when blood pressure targets were above the threshold of systolic blood pressure greater than the 10th percentile of age and diastolic blood pressures greater than the 50th percentile of age during the first 6 hours post cardiac arrest. All right, so let's go ahead and take a look at some of these algorithms for pediatrics before we jump into neonatal resuscitation. Starting off here with the BLS algorithm. So at the top here, verify scene safety, check for responsiveness, shout for help, activate the emergency response system, look for no breathing or only gasping, check a pulse simultaneously. Is the pulse definitely felt within 10 seconds? If the answer is normal breathing and the pulse is felt, monitor. And on this side, it's abnormal breathing, but you still have a pulse. Let's look what it says here. Support ventilations. Open the airway and reposition. Provide breaths, one breath every 2 to 3 seconds or 20 to 30 breaths per minute. Assess a pulse rate after 2 minutes. If suspected opioid overdose, administer opioid antagonists if available. So this is saying that hey, we have a pulse, patient's not breathing adequately. We're going to go and assist ventilations for 2 minutes. Remember, we called this rescue breathing before. In 2020, they did change the one breath every 2 to 3 seconds. So they're just doubling down. Yep, we're still doing that. Cool. Okay, so this is kind of a little bit weird here. And watch what happens here. So you ventilate this kid for 2 minutes. We're doing rescue breathing. And now we have to assess the heart rate. It states, is the heart rate less than 60 with poor perfusion despite you oxygenating and ventilating the patient? If the answer is no, it says continue providing breaths and check a pulse every 2 minutes. So it's just saying, like, hey, man, just continue positive pressure ventilations. And every 2 minutes, come back here and make that decision again. Is the heart rate less than 60 or not? Now, let's say that the heart rate is less than 60. Watch what happens here in this algorithm. It comes down and it says, was this collapse witnessed? What? Why? Why does it matter? We have a kid with a heart rate less than 60. Let's say that yes, we watched this kid collapse. Activate the emergency response system if not already done. Retrieve an AED and use it immediately. Then start chest compressions. Kind of weird. If you did not witness this kid collapse, first rescuer performs cycles of 30 chest compressions in 2 breaths. When a second rescuer arrives, perform cycles of 15 compressions in 2 breaths. Use an AED or defibrillator as soon as it's available. If suspected opioid overdose, again, man, in every algorithm now, give Narcan. After 2 minutes of you doing CPR, let's say that you're by yourself and you are still alone after the 2 minutes, now is when you're going to activate the emergency response system and retrieve an AED or defibrillator if you did not already do so. Anyone who's watching, if you are ever in this situation, and I hope this never happens to you, just go ahead and take your phone out, put it on speaker, call 911, and work while the dispatcher is on the line. Let's see what happens after this. Check rhythm. Is it a shockable rhythm? Let's do non-shockable first. Resume CPR immediately for 2 minutes until prompted by the AED or defibrillator to allow a rhythm check. Continue until PALS professionals take over or the infant or child starts to move. On the opposite side, yes, it's a shockable rhythm. Give one shock, resume CPR immediately for 2 minutes until prompted by the AED or defibrillator to allow for a rhythm check. Continue until PALS professionals take over or the infant or child starts to move. And this is for healthcare professionals. This is not for the layperson. Pretty wild, huh? They're still not telling you to do pulse checks on non-shockable rhythms for the healthcare professional once the child is pulseless. Man, when you think that they're going to make certain changes and it just doesn't happen on these algorithms, it can get a little stressful. You're going to see me get probably even more stressed out in this next one. Let's take a look at PALS. All right. Start CPR. Begin bag mask ventilations and give oxygen. Attach the monitor defibrillator. Let's go ahead and look down non-shockable first. Non-shockable, asystole or PEA. Give epinephrine as soon as possible. Just like in the highlights, states that is the most beneficial thing. CPR for 2 minutes. IV access, epinephrine every 3 to 5 minutes. They didn't change that at all. Is the rhythm shockable? If the answer is no, keep doing CPR for 2 minutes. Treat reversible causes. Reversible causes didn't change. Hypoglycemia is still there. Let's say that they remain not shockable rhythm. If there's no signs of return of spontaneous circulation, go to 10. Okay, CPR and give epinephrine again. Got it. If ROSC, go to post cardiac arrest care checklist, which we talked about that checklist in my last video. So let's go ahead and say that we do have a shockable rhythm right after we gave this first epinephrine. So we just gave this epi. We got a shockable rhythm here. Let's see what it says. Go to 5. 5 is right here. Shock. And then give epi again. What? Why? Why doesn't it say go to 5 or 7? Let's go ahead and look at shockable side. VFib repulses VTAC, shock as soon as possible. The algorithm still says nothing about is this witnessed or unwitnessed. It just says, is it shockable? Send it. CPR for 2 minutes. Is the rhythm shockable after 2 minutes? If the answer is still yes, you're going to shock again and then give your first round of medications, which is epinephrine every 3 to 5 minutes, and advance the airway. Is the rhythm still shockable after that? If the answer is yes, you're going to shock it and give amiodarone or lidocaine, then treat reversible causes. Let's go ahead and look at some of this information here on the right-hand side. It says high quality CPR, push hard and fast, 1/3 the anterior posterior diameter of the chest, no difference there. Push fast, 100, 120, no change. Allow for complete chest recoil, minimize interruptions and chest compressions. Change compressors every 2 minutes, sooner if fatigued. If no advanced airway, use compression ventilation ratio of 15:2 if you have 2 rescuers. This is pre-puberty. 30:2 if you have 2 rescuers post-puberty. This is new stuff here on the right-hand side. 30:2 if 1 rescuer of any age. If advanced airway, provide continuous compressions and give breaths every 2 to 3 seconds. No difference there since 2020. For shocking, 2 joules per kilogram. Second shock is 4 joules per kilogram. Subsequent shocks are 4 or greater to a max of 10. So I would imagine in the new PALS videos, they're probably still going to do the whole 2, 4, 6, 8. That's the dose to defibrillate, just to help providers memorize that, yeah, you can move up, right? But we can't go past 10 joules per kilogram. So no change there. Epinephrine, the dose stayed the same, 0.01 milligrams per kilogram, max dose of 1 milligram. Amiodarone, 5 milligrams per kilogram, max dose of 300 milligrams. Again, repeat up to 3 doses. Nothing changed there. Maximum subsequent doses is 150. Lidocaine, dose of 1 milligram per kilogram. Interesting that they don't say anything about subsequent doses of the lidocaine. I'm guessing that means they just want you to give only 1 round of lidocaine for pediatrics. I'll look into that. So, doing a little bit of research on this, I found that there are subsequent doses for lidocaine. And again, it's half the dose to a maximum of 3 milligrams per kilogram. But I'm a little bit concerned that If that is the case and they did not put it on here, that is crazy to me. Crazy. When advancing the airway, ET, intubation, and supraglottic airway, usual stuff. Let's go ahead and look at infant and child FBAO or foreign body airway. Starting off with the infant, it says verify scene safety, check for signs of severe foreign body airway. We all know those signs. If absent, encourage them to cough. If it is present, we're going to go ahead and activate the emergency response system. Is the infant responsive? So they're still using this terminology. Responsive or unresponsive is going to determine how we're going to perform these skills. If they are responsive, 5 back blows or slaps followed by 5 chest thrusts. Repeat until the object is expelled or the infant becomes unresponsive. So no difference there. If the object is expelled, continue to monitor until advanced care arrives. If the infant is not responsive, start CPR until advanced care arrives. Refer to pediatric BLS algorithm. Start with chest compressions. Check for visible object in the mouth before giving breaths. Pretty straightforward. For child FBAO, the exact same intro. Is the child responsive? If the answer is yes, again, 5 back blows or slaps followed by 5 abdominal thrusts, not chest thrusts. Again, repeat until the object is expelled or the child becomes unresponsive. And again, if that kid is unresponsive, start CPR until advanced care arrives. Same exact thing. So they just made the child, the adult, the infant, everyone is the same. Now, should be easier to memorize. Next, we're looking at pediatric bradycardia with a pulse. A child with bradycardia and a pulse, do they have cardiopulmonary compromise? Was it always only 3? Acute altered mental status, signs of shock or hypotension? If the answer is no, identify and treat underlying causes and support the ABCs. Okay. If the answer is yes, maintain a patent airway and provide oxygen. Assist breathing with positive pressure ventilation as necessary, and attach a cardiorespiratory monitor and monitor the patient's pulse. So I don't understand why they don't want to just say, hey, go ahead and ventilate for 30 seconds on these algorithms. It's very confusing. It just says as necessary. So I suppose while this child is hooked up to the monitor and you're bagging the child, if the pulse rate comes up greater than 60, then you move on. It's very bizarre. It doesn't give us any time frames. Then it just goes right into, does bradycardia persist? Man, it should not be this gray. They need to make this black and white. At 2 minutes, you reassess a pulse. At 30 seconds, you reassess a pulse. It needs to be that way. Any which way. This is getting me heated, and I don't need this in my life. All right. Does bradycardia persist? If the answer is yes, start CPR. If heart rate's less than 60, IV, give epinephrine, atropine. Again, man, I was hoping to see changes of all this stuff. So, how it reads is you can just start chest compressions and give epinephrine and give atropine immediately. That's how this algorithm's reading, right? It's in the same exact box. It's not like with CPR where it says give a drug, do CPR for 2 minutes, reassess, right? It's just saying, hey, floodgates are open. Go ahead and start a line and you can start giving drugs, both of them. Identify and treat underlying causes considered pacing. Check a pulse every 2 minutes if present. If there is no pulse, obviously change the algorithm. Over here on the right hand side, epi didn't change, 0.01 milligram per kilogram, max dose of 1, atropine, 0.02 milligrams per kilogram, repeat 1 time, same thing as the old algorithm. Minimum dose of 0.1 milligrams. This is to stop paradoxical bradycardia from occurring. If you give atropine too slow or you give too little bit of the drug, you'll actually cause a reverse effect, right? You'll make them become more bradycardic, which obviously that's not what we're looking for. Maximum single dose, 0.5 milligrams. And then they give you some possible causes of bradycardia. Hopefully, tachycardia doesn't make me upset. Pediatric tachycardia with a pulse algorithm. Initial assessment and support, maintain patent airway, assist breathing with positive pressure ventilation, and oxygen as necessary. Attach a monitor, IV, get a 12 lead if available. Evaluate the rhythm. Let's look over here. It says probable sinus tachycardia if there are P waves present. variable R to R intervals. Infant rate is less than 220. Child rate is less than 180. So they're just talking about sinus tach. Treat the reversible causes of sinus tachycardia. Cool with it. Are they stable or unstable? Let's say that the child is not unstable. It says evaluate the QRS duration. If it's less than or equal to zero point zero 0.09 seconds, that's a probable SVT. Consider vagal maneuver and give adenosine. Interesting. Didn't we just read in the highlights that they wanted us to give, I believe it was procanamide, amiodarone, or sotalol if adenosine and vagal maneuvers did not work? Well, it's not there. Is the QRS complex wide? If the answer is yes, possible VTAC or supraventricular tachycardia with an aberrancy. All right, they're adding a little bit of verbiage. If rhythm is regular and monomorphic, consider adenosine. Again, they do not want providers giving amiodarone to a VTAC that is stable. Let's look at unstable. And remember that unstable is acute AMS, signs of shock, and hypotension. We're going to go in and look on the left side. So remember, unstable, SVT, that's equal to or less than 0.09 seconds. If IV access is present, give adenosine, or you can cardiovert. Pretty straightforward, exactly what it was last time. Is it wide, greater than 0.09 seconds? Possible VTAC, perform synchronized cardioversion. Let's go in and look at this additional information up here, top right. P waves, absent or abnormal. R to R intervals not variable. Infant rate is usually greater to or equal to 220. Child rate is greater than or equal to 180. History of abrupt rate change. Doses, if synchronized cardioverting, begin with 0.5 to 1 joule per kilogram. If not effective, increase to 2 joules per kilogram. Sedate if needed, but don't delay cardioversion. For adenosine, IV or IO dose, zero point 0.1 milligrams per kilogram, max of 6. Consider a repeat dose of 0.2 milligrams per kilogram, max of 12. Nothing really changed here on this algorithm. Again, I don't really know why they didn't add the antidysrhythmic down here under SVT, but oh well. All right, let's get after neonatal resuscitation. Let me move myself. So it states there's 4 million births in the US and Canada each year. One of every 10 to 20 newborn infants will need help transitioning from fluid filled environments of the womb to an air filled room. It is essential that every newborn infant requiring this care has a healthcare professional who is trained and equipped for the role dedicated to facilitating that transition. Instead of jumping into these summaries, let's actually just read what changed here in neonatal resuscitation. There's the algorithm, which we'll be looking at. All right, so there's only a couple pages, y'all. It's not a lot. Hang in here with me. Let's go ahead and start here with major new and updated recommendations, starting off with umbilical cord management. For term newborn infants who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds can be beneficial when compared with immediate cord clamping. Ooh, OB doctors are going to be pissed. I feel like the amount of old school OB doctors that are out there that hate delayed cord clamping. Interested to hear what they have to say if the American Heart Association is even jumping on it. For why, it says meta analysis have shown that hematology and iron status in infancy are improved with deferred cord clamping. Recent studies that extend deferral to 60 seconds compared with early cord clamping have affirmed these findings. Non vigorous term newborn infants and late preterm infants, 35 weeks or more gestational age, intact cord milking may be reasonable when compared with immediate cord clamping. Interesting, man. Milking the cord. I would have never thought I would have seen this in neonatal resuscitative guidelines. So, milking of the cord means that they literally grab the cord and they squeeze the umbilical cord towards the infant and milk the cord into the baby. It says a large randomized control trial of non vigorous infants, 35 to 42-week gestational period, reported that intact umbilical cord milking compared with early cord clamping was associated with decreases in rates of cardiorespiratory support, moderate to severe hypoxic ischemic encephalopathy, and the use of therapeutic hypothermia. So, yeah, obviously, you don't want any of this stuff to go on with a baby. So, they're saying, yeah, cord milking between 35 and 42 weeks has positive results. For newborn infants born at less than 37 weeks, talking about a preemie, do not require immediate resuscitation. Deferred cord clamping for at least 60 seconds is recommended when compared with immediate cord clamping. Again, just saying that it's better to hold off. Delayed cord clamping. Wait till the, I'm surprised that it doesn't just say, wait till the cord stops pulsating. That's what most paramedic books say, but they're using the minute, right? 60 seconds. Okay. Ventilation and continuous positive airway pressure. For newborn infants, initial peak inflation pressures of 20 to 30 centimeters of water are reasonable, with adjustment of peak inflation pressures to provide effective ventilation. So interesting. They're saying that initial peak inflation pressure. So you might have to increase the amount of pressure for your initial ventilations, open up the lungs, right? Make it a little bit easier for effective ventilation. It said observational studies in preterm and term newborn infants have reported peak inflation pressures up to 30 centimeters of water or more, corresponding to tidal volumes that are considered adequate for newborn ventilation. Pressures can be adjusted as effective ventilation is achieved. Fair. It is reasonable to provide ventilation at a rate of 30 to 60 breaths per minute in newborn infants. Interesting. So they went from 40 to 60 to 30 to 60. Okay. An observational study reported that ventilation at a rate of 30 to 60 breaths per minute resulted in delivered tidal volumes between 5 mLs per kilogram and 10 mLs per kilogram. An observational study of late preterm and term newborns reported that inflation rate of 30 breaths per minute was associated with the highest carbon dioxide clearance. Interesting. Video laryngoscopy can be useful for newborn infants who require endotracheal intubation. It says that they used a meta-analysis of 6 randomized controlled trials to make that decision. Involving intubations, video laryngoscopy compared with traditional laryngoscopy led to increased intubation success. Who would have thought? Reasonable to use a laryngeal mask as an alternative to endotracheal intubation for newborn infants at 34 weeks or more gestational age for whom ventilation via face mask is unsuccessful. Interesting. It says for randomized controlled trials, there was no significant difference in insertion time or first attempt success with a laryngeal mask or supraglottic airway as a secondary device instead of endotracheal intubation after face mask ventilation was unsuccessful. In one observational study, the use of an LMA instead of an endotracheal tube was associated with decreased admission to neonatal intensive care unit. Instead of tubing a newborn is now an option, and it's backed by science. Next one, it may be reasonable to use an LMA as the primary interface to administer ventilations instead of a face mask for a newborn infant born at 34 weeks or more gestational age. Did a lot of work on LMA use. Last couple here, we got oxygen and chest compressions. For oxygen, a pulse oximeter should be placed as soon as possible for newborn infants receiving respiratory support or supplemental oxygen. I would say even sooner than that, right? And we'll talk about that with the neonatal resuscitation algorithm. Placement of a pulse oximeter early in resuscitation results in earlier reading of oxygen saturation for guidance of therapy. In observational studies, median time to obtain pulse oximetry ranged from 238 to 260 seconds and was longer in preterm infants compared to term infants. Next, it says in preterm newborn infants born at less than 32 weeks, wow, very preemie, receiving respiratory support at birth, it may be reasonable to begin with 30% to 100% oxygen. Interesting. So I guess instead of room air, they're actually starting the resuscitation with O2. Let's see what it says why. Analysis of available studies for this population have led to conclusions that conflict with those of a study level meta analysis of 10 randomized controlled trials showing no difference in short term mortality when initial oxygen concentrations were low compared to when it was high. with low oxygen generally being considered room air, 21 to 30%, and high oxygen, 60 to 100. A recent individual patient data meta analysis found that high initial oxygen concentrations of 90 to 100% was associated with lower mortality when compared to a low initial oxygen sats of 21 to 30%. Oxygen concentration can be titrated down as targets are achieved. Interesting, but remember this is for preterm newborns, right? So hold off on blowing 100% O2 on neonatal resuscitation in the beginning, right? That was an analysis that was performed for preterm newborns less than 32 weeks. Let's take a look at chest compressions, and then we're going to go in and look at the algorithm itself and call it. So for chest compressions, it may be reasonable to compress over the lower third of the sternum, taking care to be above the xiphoid process when providing chest compressions to newborn infants. So, an autopsy study of infants and young children found that providing mid sternum compressions was not associated with liver rupture. Superficial tears of the liver capsule were produced when compressions were applied to the xiphoid process, and all patients with simultaneous chest compression and abdominal compressions or abdominal compressions alone had liver rupture. Chest radiograph studies identify that the heart lies under the lower third of the sternum in most infants. Last thing, it may be reasonable to change compressors every 2 to 5 minutes when providing chest compressions to newborn infants and to switch compressors while heart rate is being assessed. It states high quality chest compression encompass multiple factors, including optimal compression to ventilation ratio, adequate rate and adequate depth of compression, and full recoil between compressions. Neonatal mannequin studies demonstrate that the compression quality can diminish by 2 to 5 minutes when a single clinician performs compressions. Let's take a look at this algorithm and let's see if anything changed. At the top, we have birth initial cord management plan. Interesting. I wasn't sure if the cord management plan was going to be spelled out. It's not. That just says cord management plan. Term gestation, is there good tone? Is the child breathing or crying? If the answer is yes, go with skin to skin with the parent, routine care, maintain normal temperature, and ongoing evaluation. If the answer is no to term gestation, good tone, or breathing or crying, warm and maintain normal temperature, dry position, stimulate and clear airway if needed. I feel like they should have said clear airway if needed first before drying and positioning and all that stuff, but that's okay. We get it. Is the child apneic or gasping? Is their heart rate less than 100? Let's say no. Let's say that the kid is breathing. Labored breathing or persistent cyanosis, pulse oximeter, and oxygen if needed. Consider CPAP. Interesting one. Post resuscitative care, communicate with family, and perform team debrief. Now let's go ahead back up here and let's say that the heart rate is less than 100 or the child is apneic. Ventilate, pulse oximeter, and cardiac monitoring. Just like with PALS, they decided not to give us an exact time frame, even though they have this one here of 1 minute. They say that all of this should be done in 1 minute. Okay, I agree with that. But I wish they would have said ventilate for 30 seconds. They would have said something further more about this ventilation on this algorithm, but they did not. Does the heart rate remain less than 100 after those ventilations? If the answer is yes, ventilation corrective steps, consider intubation or an LMA and cardiac monitor. Is the heart rate less than 60? Let's say no, but it's less than 100. Continue ventilation and corrective steps. It just keeps going in that loop. If the heart rate is between 60 and 100, we're just going to continuously give ventilations. That's exactly how it was before. Now there is definitely kind of a push on using an LMA to deliver these ventilations. And we're going to do this every minute, every 30 seconds. I'm guessing just from the look how long this minute is. So this is half that. So again, 30 seconds of positive pressure ventilations before you reassess this heart rate. I shouldn't have to guess on that, but I am. I would say 30 seconds. I know that's how we've always done it in the past, I was just hoping these algorithms were going to be a little bit more black and white again. Now, is a heart rate less than 60 beats per minute? If the answer is yes, intubate or LMA. Do chest compressions and coordinate a 3-to-1 ventilation to chest compression with 100% oxygen. Interesting. So they're saying use 100% oxygen if the heart rate remains less than 60, not necessarily keeping on track with our target oxygen saturation table. So my guess is, despite what minute we're at in this neonatal resuscitation, if you start doing chest compressions, we are now hooking up 100% oxygen. It says obtain an umbilical vein catheter or an IO. Does the heart rate remain less than 60? If the answer is yes, we're going to give epinephrine every 3 to 5 minutes. And that is still cardiac arrest epi, is my guess, because it doesn't say anything on there. If heart rate remains less than 60, consider hypovolemia and consider tension and consider a pneumothorax. So, yeah, as a healthcare provider, as somebody who teaches neonatal resuscitation, I could tell you my opinions about a lot of these algorithms, and I wish I would see things spelled out a little easier for somebody who is newer coming in. Many things are ambiguous, man, and for honestly no reason, right? I do think there are some good changes here. I think if you know neonatal resuscitation, this algorithm is still manageable. You still know that, hey, we're doing 1 minute rotations, not 2 minutes. Now, again, my guess is that this algorithm is for people who have taken the class only and that they understand how to perform neonatal resuscitation. But yeah, if you're somebody else looking at this, I promise you're going to be a little bit lost on when to perform certain things and how things are done with neonatal resuscitation. All right, guys, this is going to wrap up my pediatric and neonatal resuscitation highlights for the 2025 AHA algorithms and guidelines. I hope me reviewing the highlights, you've gotten something out of that. It's always good for me also to review this. This was actually my first time reading through the pediatric stuff. So there were several things that obviously you can tell by how I was acting reading the algorithms. I was like, oh man, I hope they change this next year. But hey, they didn't. We got another 5 years. Let's see if there can be some more changes then. So, again, as always, if you have any questions, please reach out. And I wish you guys the best. See you on the next one.